So for the first Show Me, we are going to be talking about epidural use in labor. So first off, we're going to talk about the diagnosis and the definition. So an epidural is a local combined analgesic and anal anesthetic. So the anesthetic is the bupivacaine and the analgesic is the morphine or fentanyl, depending on the type of epidural being used. And it is injected into the epidural space at the 4th or 5th vertebra. It eliminates all sensations below the umbilicus and in such relieving the discomfort of labor. And an epidural can last anywhere from 1 to 3 hours, and it usually takes about 30 minutes to 60 minutes to have its full effect for the mom. So like with any procedure, there's always risk factors. So in the case of epidural, the risk factors are maternal hypotension, fetal bradycardia, the inability to feel the urge to void, the loss of the bearing down reflex, something called a CSF headache, which is cerebral spinal fluid. That would usually occur if mom was laying down straight or if something went wrong during the actual procedure itself. Pruritus, and of course it being not successful. So if something went wrong during the process, or depending on the technique used by the provider, it could not provide the correct dose of analgesia, and mom could still feel the pain of labor. Complications that arise with an epidural. So there was a study done at the University of Texas Southwestern Medical Center, and this is one of my articles that I used. So a couple of researchers there concluded that the incidences of epidural analgesia related to complications that was found was actually really low when related to pregnancy. So epidurals can be used for different reasons, but when related to pregnancy, there was really minimal to no complications found. So they had a sample of 100,000 pregnant women, and they all received epidurals. So 0.6% had a spinal hematoma, and 0 had a related spinal abscess. So those were the two most common complications that they found, and one of them nobody had out of all the sample. So then it was also determined that some risk factors of complications, which could have indicated 0.6%, would be actually being a patient in a teaching hospital and the increased length of hospital stay, because that can always increase your risk for infection and complications. And then for diagnostic procedures and testing. So an epidural is administered when mom is in active labor and at least 4 centimeters dilated. The continuous infusion is administered through an indwelling catheter. So when they inject the needle, they then place a catheter into mom, into the epidural space in the back, and that's what allows mom to have kind of like a PCA pump and continuously give herself medication as needed. And it is performed by an anesthesiologist, and it is, of course, a sterile procedure. So the next thing I'm going to talk about is incidence. So the second journal article I found was another study, and it actually took place outside of the US. So it was done in India, and it found that education provided to moms regarding epidurals, once they provided education, 102 first-time mothers were provided the information. So 59% were ready to request an epidural during labor once they were educated. Before they were educated, only 33% of moms even knew what an epidural was, and even knew that any type of any analgesic could be an option during pregnancy. Some moms didn't even know that you could go through labor with having an analgesic option. They just thought natural was the only way. So that was really interesting to read about as well. And then inside the US, so then according to the American Pregnancy Association, more than 50% of women who give birth in a hospital setting receive epidurals. So obviously it depends on, if you're doing it at a birthing center, at your home, or what have you, but in the hospital setting, that would be 50% receiving epidurals. So the third thing is the nursing diagnoses. So I have 2 here. So the first one I did was risk for falls related to pharmaceutical agents, as evidenced by a decreased lower extremity sensation. And that would be just because mom can't get up, can barely lift her legs by herself. So obviously there's a high risk of injury during that time. And then the second nursing diagnosis I had was risk for infection. and that's related to an invasive procedure as evidenced by the epidural analgesia. So anytime a foreign object is placed into the body, there's always that risk for infection. And the fourth thing we're going to talk about is the pathophysiology. So the mechanism of action. So an epidural works via injection that enters your epidural space, which I talked about earlier, and that's basically the dura mater that protects your spinal cord. And it's given typically through the third or fourth and fifth vertebrae of your spine. So it also can be considered a block, and it basically prevents pain signals from going to your brain. So the pain medication is administered through a catheter that is inserted into your epidural space. And then, like I was saying earlier, the PCA pump allows mom to control the administration of the medication if she feels it's not working enough, working too much. Specifically, epidurals target the nerves that transport pain signals to your brain. And it has been shown that epidural analgesia does increase the duration of the second stage of labor and may increase the need of oxytocin to assist with labor. So it's really important for us to educate mom on both the benefits and the risks so that she can make an informed decision on which path she'd like to take and for us to support whatever path she chooses. And then it also said that the effectiveness is based upon which medications are used in the epidural and the provider's technique. So for the medications, it could be the morphine or the fentanyl, which combination they choose to use. So to get into the medications, so medication and dosages. So for the opioids, it's either morphine, which is 2 to 5 milligrams, Demerol, which is 25 to 75 milligrams, and that's the... Actually, I'm sorry, I don't think Demerol is actually supposed to be there. I think I meant to take that one out. I believe the only two are morphine and fentanyl. So ignore the Demerol, that's not supposed to be there. The fentanyl is 50 to 100 micrograms, and then the morphine is 2 to 5 micrograms. And then the local anesthetics, which would be lidocaine, which is 50 to 100 milligrams, or the bupivacaine, which I talked about earlier, which is 75 to 150 milligrams. So some contraindications to receiving an epidural for pregnancy would be a history of spinal surgeries, spinal abnormalities, coagulation defects, cardiac problems, any active infections, actually obesity, hypovolemia, and any woman who's receiving coagulation therapy. We don't want to increase that risk for bleeding, especially not while in active labor. Some side effects would be nausea and vomiting, hypotension, fever, pruritus, allergic reaction, respiratory depression, fetal distress secondary to maternal hypotension. So we really want to keep a close eye on not only mom, but on baby as well. And then for nursing implications. So we definitely want to ensure mom avoids supine position, as that will minimize the hypotension that could occur as a side effect. We want to keep her in either sitting up or side lying, really kind of having her back curved to maximize the area of where the analgesia is at this time in the spine. We also want to give a bolus of IV fluids to help with the hypotension as well. And we want to coach her in pushing efforts, so we want to make sure she understands the importance of pushing, even if she can't really feel the sensation any longer. We want to monitor her vital signs closely, so like discussed before, hypotension is a side effect, fever is a side effect, and respiratory depression. So we really want to keep an eye on not only baby's vital signs, but mom's vital signs, and especially SpO2 to really monitor for any signs of respiratory depression. We want to assess the fetal heart rate regularly, like I said. We want to maintain a patent IV to make sure if anything was to happen, any reactions, anything that needed to be done emergent, we already have that IV access. We want to have oxygen close by in case of respiratory depression. And we want to assess her bladder for distension and encourage urination at least every 2 hours. She's not going to really have that urge to go anymore, but we know that your bladder can swell and basically block the birth canal, so the baby will have a hard time coming out if that bladder's in the way. We want to monitor her for safety, really ensure that she's not getting up without assistance, that she understands any risk, that she knows that she won't be able to walk right away. And then after delivery and after the anesthesia epidural, we want to monitor for the return of her sensation to baseline. The last thing I want to talk about is patient education. So a couple tips I have written here would be request assistance with ambulation and changing positions, educate mom regarding the PCA, proper way to use it and when to use it. We want to teach her bearing down techniques. We want to ensure mom understands the benefits and the risks of the epidural. We want to stress to her the importance of urination. We want to express to her the expected outcomes, both being good and bad that could occur, and of course opioid education because she is receiving opioids at this time.